Hi, I'm Sherry Harlan Davis, and welcome to this episode of Reid Beside You. And today we are discussing about our advanced provider practitioners. And today our guests are Chris Pruitt, who's a physician assistant, and Jeffrey Barron, who is a nurse practitioner. Welcome, gentlemen.
Thank you.
And as we get started, let's give me an understanding on how you came into your profession, as well as your background and how you came to Reid. So, who wants to be first?
I'll go ahead and go.
Okay,
So,
Chris?
I graduated from the military's PA program in 2003. I came to Richmond area in 2004, working with Dr. Neer in orthopedics. We were taking care of patients in the area and working at Reid Hospital. We became official Reid employees, I guess, if you will, around 2012, I think it was. So Dr. Neer and I have been working together for about 16 years now. Yeah, that's it.
Well, great. And Jeff?
I became a nurse practitioner in 1995. And I actually at the time lived out on the East Coast and went to my graduate school at Catholic University in Washington, D.C. And then I had been working locally in this area with Dr. Weg beginning in 1999, so about 21 years now. And we joined Reid Health in 2013, so about 7 years ago. And I've worked in family practice all along with Daniel Weg, and then also I have two other nurse practitioners who also work alongside of us as well.
Then with your career, and how did you come with, you both have different areas. So explain how you chose the practice and how you decided what you would like to practice in your specialty.
Well, as a physician assistant, actually the first job that I got out of school, I was trying to make my way back to Indiana, was with an ear, nose, and throat group in Bloomington. And basically I was running their allergy clinic for them. But it wasn't a great fit. It wasn't a terrible job, but it wasn't really me. And my wife wanted to get closer to her family and her hometown. So job opened up with Dr. Neer at the time. I knew I would like orthopedics. I was an x-ray tech before. So I was all on board for moving back here to Hagerstown, which was her hometown. And yeah, I know the rest is history. So I really like orthopedics. It's very procedural. I can't imagine doing anything else. If I did anything else, it'd have to be procedural. I like the hands-on and doing procedural type stuff. Clinic is part of it. I like doing a little bit of everything. It's clinic, call, going to the ER, going to the surgery, rounding. So I enjoy that.
Jeff?
Yeah, so I had first started out. I was lucky enough to get to have a scholarship for my graduate school through the VA, through the Veterans Administration. And when I first started working and when I first graduated, I was certified as an adult nurse practitioner. I worked 2 years at the VA in downtown Detroit. And then moving to this area, upon arrival, I quickly realized everyone does family practice around here. It's a rural area, and you're really expected to take care of all age groups. So the first thing I had to do was go back to school again and get a postmaster's certificate as a family nurse practitioner. And then, so then I was able to take care of all the different age groups. So being I guess a true family practice, we take care of everything from newborn babies after they leave the hospital to young adults and middle-aged adults, and to the elderly and geriatrics and end of life. So we have a true wide scope. We do some occasionally house calls even, and that's an area that's kind of coming back again, quite honestly. So we do a little bit of that. I have to say Dr. Wake does more of those things, but longtime patients, we also will see them, in their home if they need be. So that's a little something else that we get to do.
One of the questions we receive a lot, and from a community standpoint, what's a nurse practitioner and what's a physician assistant? So.
Go ahead, Jeff.
Okay, I think I started off on that. Sounds familiar. So that question is often asked, and because there's a lot of overlap with the jobs that we may be employed in, there's a lot of overlap with responsibilities. The thing I tell most folks, to become a nurse practitioner, you're a registered nurse first. You're an RN with a bachelor's degree. That's the standard these days. And then you go on to your graduate school to become a nurse practitioner. There are different areas that you can train in as a nurse practitioner. For example, I'm a family nurse practitioner. There are pediatric nurse practitioners who, of course, specialize in just the pediatric population, psychiatric, who just work with mental health. There's midwives, which is another specialty, women's health nurse practitioners. So those are the NP roles. And with physician assistants, they can come from lots of other roles before they become a physician assistant and enter graduate school. And so that's one of the biggest difference. A nurse practitioner is always a nurse first and then learns the advanced practice. Physician assistants, PAs, can come from lots of different backgrounds and go on to their graduate studies and become a PA. But Chris could probably say something else about the PA end.
Well, that sounds good. Yeah, right on. I was an X-ray tech before, and I think I had mentioned before too. I had a lot of different people in my class. We did have an RN. We had lab techs, paramedics, Navy corpsmen. We actually had one guy who was a cop. He used to joke around saying he thought he was an experiment or something. He was Air Force SP, but so lots of different backgrounds.
And one of the things in our area, we actually are a rural hospital system, which often people don't understand, but we are a rural hospital system, and the role of the advanced practice providers really helps out in this area. So as we're looking at that, and approximately how many advanced practice providers are you aware of that we have at Reid?
I think the number is over 100 now, between the NPs and the PAs. Just a little over 100, I believe, in that ballpark.
And one of the things with us being a rural hospital system, that there is a nationwide shortage of physicians. So this is such a great accomplishment to be able to have people like yourselves added to our hospital system. Mm-hmm. And the next thing I want to discuss is relationships. And being a rural health provider, you really are part of that huge relationship that some people only see you, or they want to only see you. So can you share some experience on that?
Yeah. You want to go first?
I'll go first. Go ahead, Jeff.
Yeah. So what I always say is we're part of a healthcare team, the nurse practitioner and the physician, and same with the PAs. It's difficult to attract physicians to rural areas, it seems. It seems like unless you maybe grow up in a rural area, they don't tend to be as attracted to it, or maybe there was a rotation in school at the rural area that they really hit it off with, and they may be attracted. But it is difficult to get physicians to rural areas. That's just an aside. But as far as the team goes, there's just not enough physician to go around. And as advanced practice providers, NPs and PAs, we were able to fill in the gap, and we're able to provide services to our patients that if they didn't receive from us, they probably wouldn't get them. And so at least myself as primary care, that's, preventive health from the time the baby comes out of the hospital and all their well checks and, and all the chronic care of all our other age groups. So we work together. We're always, I work out of two different offices. So when I'm in one office, Dr. Wegg or one of the other NPs is in a different office. So we're meeting the needs by sort of moving around and sharing the workload. And when one of us is gone, then one of the other providers fills in and takes care of things. So it's really a team approach. And I think that's what it takes to be successful in delivering high quality care. And I do think our care is equal to or better than care in any metropolitan areas. I think we do a lot better with things not getting lost. There aren't so many moving parts. So I think we do a really good job.
Chris? You have something to add?
Yeah, in a surgical specialty, obviously, like specifically, working with orthopedic surgeons, these are really busy, professionals. There's not that many of them around. And having someone like me who can work as a, kind of a force multiplier, I can help him see more patients and take care of his patients so he can focus where, he's really needed, which is in the OR, fixing broken bones and replacing joints, and I help him out in the OR too, so that, we've got a team and we've been doing this, like I said, 16 years. It's just like a dance, there's steps, and we're very smooth, and we each know what the other one's expected to do. And so he's much more efficient. Seeing patients, rounding on them in the hospital, doing consults, seeing more patients here in the clinic, post-operative care. I'm able to help him out with that load so that he's able to, take care of more patients. So that's where I think patients see the advantage of having me here. I mean, certainly if they come in and for some reason say they really just want to see the surgeon, and they may be told, well, the surgeon's booked up for, a week, maybe 2 weeks. But we can get you in with the PA today or tomorrow, then, it's just immediately evident the value of having me here. So, yeah.
I was looking at a quote from the Journal of Medical Care. It said that in older diabetic patients who received all of their primary care from NPs had lower rates of potentially preventable hospitalization. So that also shows the just the success of working with the advanced providers. Can you share some examples of just with your relationships? And both of you have been with the Reid Health System for over 15 years. So some of the relationships, and you're probably now seeing another generation of people as well. And when you first started.
Yeah, that is one advantage to working in a rural area is, you know these people. You go to church with them, you see them at the grocery store, you see them at your kids' Little League games. They catch you, coming out of church and want you to look at their shoulder, but it's great, these people and they know you, with my role in particular, I may see a patient, diagnose them, treat them, work with them over a period of time on a condition. And then when it's time that we need to talk about surgery, then, that's when they meet Dr. Neer and they have their surgery, and they may, continue post-operative care with me. We don't force them to do that. They always have the option to see the surgeon anytime if that's what they choose to do. But, you build that relationship with these patients, and I have patients that they want to make sure that I'm going to be there, on the day of their surgery. They'll want to see my face too. You come in and I want to see your face, you're there. So, and that's, obviously that that's huge. You know, that's a big thing that I think you miss in a big metropolitan area. And it's one of the things that I enjoy about working in a rural area.
One of the things you mentioned earlier is about quality of care and studies and about outcomes. You know, that's the thing we hear about today. That everything is evidence-based medicine. We have to do things that's founded in science and outcomes. We have to make sure what we do is measurable in a positive way. So there are lots and lots of studies in the nurse practitioner literature and the PA literature about equal, if not better than outcomes with lots of management of lots of chronic diseases and acute processes. So when someone sees an NP, a PA, they're not getting lesser care than they are from a physician. They may be a different approach than the physician may have, but there's lots of research to show that our care in most conditions is equal to, if not better than, in a lot of ways. That's not to say see us, don't see them by any means. It's just to say we're a different type of provider, but the quality that we provide is really top shelf. And I think patients know that. Especially, I look back years when I first started, and people would say, "Oh, you can see Jeff today. Dr. X is busy," and they'd there was a little skepticism. Well, what's an NP exactly? And we've come a long way with that in our profession, with familiarity. And as always, if they say, "Hey, I want to see the doc," then that's just fine. You don't want to be sitting before you someone who's not interested in looking after you that day. So, they're welcome to do that as well. So back to the team approach. We get the patient care done together.
And I know that we had just discussed about how you came to figure out what you wanted to specialize in. And how does that affect? Do you just primarily stay in that area, or when you said as a team approach? Give me some examples if you have to consult on other things at all.
Okay, I can start there. Yeah, so the one thing about being in family practice, we are generalists. As the saying goes, we're a jack of all trades and a master of none. So, we really learn how to take care of a little bit of everything. And the majority of the things are common. You see them again and again. But so you may be required in a given day to be doing a pediatric focus, well checks on children, and then later on you might be doing a minor procedure of an abscess, and so you're doing sort of some procedural, I won't say surgery work, but it's a procedure. And later on you may be managing somebody's chronic condition, their diabetes and heart disease. So we in family practice are in a little bit of everything, and certainly in a rural area, you're asked, I think, to do a little bit more because you just don't have the resources down the hall. In my first couple of years in the VA, if there was something where, gosh, I'm just not sure, you walk down the end of the hall and ask the ear, nose, and throat surgeon to look at something. Well, that's not really so much an option when you're, out here. So you make an assessment, you make decisions, and maybe you're on the phone collaborating, or maybe you're using a camera showing it to a specialist, and or asking an orthopedic person off-site to look at something. So it's a little different, but it definitely makes you utilize all of your skills.
And on another note, we are privileged that both of you also have a military background. Can you give me some highlights of moving from more of a military to the rural healthcare?
Military medicine is, I don't know, there's a little bit of that too, right? There's a close community of people, and you're taking care of people that you see and work with. But it is a little bit different, especially if your care is focused on the soldiers. You're taking care of, a subgroup of people that are, by most respects, healthier. A lot of the I guess the big difference in military medicine, a lot of your training focuses on trauma and mass casualty, wartime, concerns, right? Dealing with nuclear and biological, warfare and the different kinds of injuries that you might encounter. So there's that aspect of it. There's this whole kind of relationship you have with your patients too, because you're in the military, you have a rank, there's a certain degree of, respect and authority that you have that you don't necessarily have here. You're going to have to earn it here, right? You're taking care of some mom's little kid, you better take good care of her kid or she's going to rip your head off, so it's different, I mean.
And that's the highest rank you can get. So
yeah.
Exactly. Yeah.
Jeff?
Yeah, I'd say there's a couple things. Definitely what Chris has said, there's no question. Resources are a little bit different, and that thing called insurance, which is a thorn in our side, and I never, as best I can remember, I don't ever recall not being able to get a test done or a procedure done for a patient. You just got it done. You asked for it, it got done. However, on the current day world with insurance dictating a lot of things, unfortunately, you really, that's another battle that you're up against with, something needs done and you can't do it or you can't prescribe that medication. And that makes things challenging. I think it makes us, again, probably better practitioners because you have to find workarounds and find other ways to get what your patient needs. So that provides a little bit of challenge. The other thing, the not having a rank structure, certainly when you're in the service, and like Chris, you were probably enlisted and then you're an officer both.
Yeah.
It's called a Mustang, being on both sides. But but anyways, there's that certain respect you get. I mean, you line up your group for the night, and there's a rank structure, and you go to work. It's definitely different on the civilian side. But anyway, that's what I'd have to say about that.
The other thing, just as we've discussed what you advanced providers do with, what would you say to a person that was considering moving into this area? What's your experience, the good experiences that you've learned to moving into a rural area?
Who's on? All right, I'll speak. I really encourage folks to do it. You get a lot of autonomy in a rural area, which is really nice, I think, especially after you got your feet wet and you're worked a couple of years and you feel pretty comfortable out there. And you'll get to use all your skills. You really will. I mean, it's as I said earlier, you become more of an expert in a rural area because you're just tasked with taking care of more things independently. So I think it's a great quality of life in a rural area. Things are, there's just lots of things you don't have to deal with. Traffic, and I have always found our patients, they're there to get our advice. They're not coming in with so much with their Dr. Google and internet diagnosis, and this is what I demand. And because I have colleagues who work elsewhere, and there's a lot of that. And so I find in the rural area, people are just more like I am, more interested in what you have to say and not so demanding, and just makes for a better relationship, I think.
Any comments, Chris?
Well, I don't have much to add. I mean, that pretty much sums it up. I mean, yeah, I think it's a better quality of life, and certainly as an APP in a rural area, like Jeff said, I mean, there's a lot more opportunities for autonomy, and I guess you just feel more appreciated and more impactful on the community and the healthcare than you probably would. I would imagine it would be pretty easy to get kind of lost in a major metropolitan area and feel not as impactful or appreciated, and I certainly don't feel that you have that issue here. So. Well,
I'd like to add that we truly appreciate having both of you in the community. And we appreciate everything you do for your patients and for Reid. And with that, I'd like to say thanks for joining us today with our guest. And thanks for joining us today on Reid Beside You. Thank you.